not all myelofibrosis is the same. Now that we have multiple different JAK inhibitors, we can start to tailor the use of a JAK inhibitor specifically to the MF patient. And although each MF patient is quite unique, we could put them into two general categories. The first category being cytopenic myelofibrosis. Those are the patients with the low blood counts. These are usually primary myelofibrosis. They tend to have a lower JAK2 allele burden and tend to have a poorer prognosis. And on the other end of the spectrum is the myeloproliferative myelofibrosis. These are the MF patients who have very usually robust or elevated blood counts. In general, can commonly be for example, a post-PV myelofibrosis patients, and these patients tend to have a better prognosis. So when you're, treating a myelofibrosis patient, good general rule of thumb is to maybe put them into one of these categories. So at the present time, we have approved 4 JAK inhibitors, ruxolitinib, which has been approved for over 10 years for myelofibrosis, as well as polycythemia vera, fedratinib, which is approved for upfront myelofibrosis, and more recently, pacritinib and momelotinib, which are approved for myelofibrosis. Pacritinib is approved first line for platelets under 50 or second line in any patient, according to the FDA. And then momelotinib is approved first line for any anemic myelofibrosis patients. So how to choose a JAK inhibitor? Because ruxolitinib has been around for quite a while, many current myelofibrosis patients are on ruxolitinib. But if one is starting with a fresh myelofibrosis patient in the era of having 4 JAK inhibitors available, one can really select an upfront JAK inhibitor that is tailored to the specific myelofibrosis patient. For ruxolitinib, patients who have an enlarged spleen and symptom burden yet have robust counts, ruxolitinib is a very good choice because it may also give you the benefits of some cytoreduction if that's what you're looking for. And in terms of cytopenic myelofibrosis patients, we have 2 options that one can think about, pacritinib and momelotinib. If a patient has platelets less than 50, upfront pacritinib is approved. Momelotinib is approved for patients who are anemic. And in terms of the patients who are anemic and thrombocytopenic at baseline with platelets less than 50, one can choose either pacritinib or momelotinib. Then moving on to a non-JAK inhibitor, we really focus on JAK inhibitors in myelofibrosis, but it is important to think outside of the JAK inhibitor box. Luspatercept is an interesting agent to utilize for anemia in myelofibrosis. It is a erythroid maturation agent and can be used to address anemia in other diseases, for example, for patients with MDS with ring sideroblasts. And interestingly, some myelofibrosis patients can also have coexisting SF3B1 mutations. So this might be particularly helpful for those patients.